Good morning, everyone from JIPMER Puducherry. I'd like to congratulate the organizers and organizing committee for this virtual conference and wishing them a grand success. And I will also thank the organizing committee for giving this opportunity. Without wasting much time, Dr. Jame Joy. He did his MBBS from Kota Medical College and MD Anesthesia from WIMS Bellary. Currently, he's doing DM Neuroanaesthesia from JIPMER Puducherry. And his topic is recent trends in depth of anesthesia monitoring, thinking beyond numbers. And Dr. Jerry, you can take over.
Good morning to all. In this occasion, I would like to thank the organizers of ISNAC 2022 for providing me with this opportunity, and my teachers, Dr. Prasanna sir and Mugilan sir, for guiding me with this presentation. So as already told, my topic for today is recent trends in depth of anesthesia monitoring, thinking beyond numbers. So when we discuss about depth of anesthesia monitors, we have an n number of depth of anesthesia monitors, and most of them we are using in our daily practice. So basically, these are processed EEG monitors, which provide us with an arbitrary number or an index, which help us in guiding the depth of anesthesia. So this table shows the target range of surgical anesthesia for various depth of anesthesia monitor, and we are familiar with all these numbers. So initially in early 1930s itself, they have started using raw EEG to analyze the depth of anesthesia. So later they found out that it was too complicated because they were not able to find out a relationship between the EEG pattern and the anesthetic brain state and the exact pathophysiological mechanisms. And many of the clinicians found it extremely complicated to analyze the EEG under anesthesia. And this raw EEG had so much external artifacts and external interferences. So it was so the use of raw EEG for analyzing the depth of anesthesia gradually declined over the period of years. So then came in early 1990s the concept of processed EEG, where the raw EEG has been processed to form a processed EEG, and subsequently they apply an algorithm to arrive at a number or an arbitrary index. So this will help us in guiding the depth of anesthesia. So this is basically how a depth of monitor works. So basically, signals are converted to digital signal by the analog to digital converter. Then once it is done, next step is pre-processing. Here, when during pre-processing, the machine analyzes which part of the EEG has to be analyzed. So after pre-processing, next step is algorithm. Application of the algorithm. So in the first step, the artifacts are removed from the EEG signal. So the main artifacts which comes are the cardiac activity, from the EMG, from the frontal muscle activity. So the reliability of a depth of anesthesia monitor depends upon the quality of artifact rejection. So after artifact rejection, the next step we'll obtain a new signal, and this signal is compared with the signals in the database. Usually the database is obtained from young individuals. So after it is the obtained signal is compared with the database signal, and subsequently they will arrive at an index number. And after the index number is obtained, the next step is post-processing. In post-processing, they will average the index values over a period of time so as to minimize the fluctuation in index values. So what are the disadvantages with these index values? Basically, as already mentioned, we have an inherent delay because multiple steps are there, and those index number, what we see, it's not an instantaneous value. It is usually an average value over a seconds or a minutes. So then the next step is these monitors have some problem with some drugs. For example, with dexmedetomidine, there will be an increase in frequency towards the slower waves. So this might give false low values, even though the patient might be easily arousable. And similar is the situation with ketamine also. It can cause increase in false high values, even though the patient may be sedated. Now, as already mentioned, the database is usually obtained from young individuals. It is not sure whether this depth of anesthesia monitor will provide reliable values in pediatric individuals, because the cortical development is not fully achieved. Similar is the situation in elder patients also, because with increasing in age, there is chances of cortical degeneration. So it may not be appropriate in elder individuals also. Then the most important thing is the clinical context. These monitors does not take in the physiological parameters of the patient. So we have to interpret the numbers based on the clinical scenario or the clinical condition of the patient. So should we see the number alone? So in our anesthesia monitor, we always have a waveform along with the number. So we always see the waveform and the number. Even if you see for blood pressure, we'll see the arterial waveform, and then only we'll see whether the value is correct or not. Similar is the situation with pulse oximeter also. Always we'll trust the waveform, then we will see the number. Then only we will come at a conclusion that the number is the number which is trustable. Even for ventilator parameters also, ETCO2, though it gives a number, we always see the waveform also. So we should always see the EEG waveform as well as the index number or the number. So we should not lose valuable information by just using only an index number, because this EEG provides us with rich information about the state of the brain. So we should consider both the EEG as well as the index number. So why raw EEG analysis has become a challenge? Because when you see an ECG, we have a regular repetitive waveforms are there, which is not seen in an EEG. We don't have a regular waveform, a repetitive waveform, or a definitive waveforms are not seen. What we usually see is the frequencies and the amplitudes. Then like that, we'll classify the EEG frequencies into different classes. 5 classes are there: alpha, theta, delta, beta, and gamma. So if you see we know that delta frequencies are slower frequencies, and gamma and beta are higher frequency waveforms. So if you see the waveforms, we can easily interpret that these waveforms looks like a higher frequency waveform, and these waveforms are slower frequencies with higher amplitude. So under anesthesia, or when the patient is awake, usually we will have a higher frequency waveforms, higher frequency, slow amplitude waveforms. With increase in depth of anesthesia, there will be change in EEG waveforms from higher frequency to lower frequency, higher amplitude waveforms are seen. So with increase in depth of anesthesia, the waveforms changes to lower frequency, higher amplitude waveforms. So these are the patterns what you see under general anesthesia with propofol. So when the patient is awake with eyes open, here we can see higher frequency oscillations are seen. When there is paradoxical excitation, we can see beta oscillations. When the patient is under sedation with propofol, here we can see predominantly alpha and beta oscillations are seen. See, if you see compare between A and C, we can see that A frequencies appear higher frequency. Here the amplitudes are also more. So there is a shifting towards lower frequency waveforms. So this is when you are using propofol for maintenance of anesthesia, you will get predominantly slow waves and alpha oscillations. And during induction, you will get predominantly delta oscillations are seen. You can see higher amplitude, slower frequency waveforms. And this is burst suppression. And with further increase in concentration, we will get an isoelectric EEG. So when you see an EEG waveform, it looks complicated, because actually an EEG waveform is formed by multiple waveforms superimposed on it. So if you analyze this EEG, we can see multiple waveforms in the EEG. So here we can see a one sine waveform going like this. Along with that, you can see another waveform which is of higher frequency waveform. So this is how an EEG waveform is formed. So analyzing the raw EEG is very difficult, looks difficult. So now comes the concept of spectral analysis. Now spectral analysis is used to decompose the EEG waveform into its component EEG waveforms. So if you see this EEG waveform, the component waveforms are extracted from the parent EEG waveform. Usually we'll see alpha oscillations and delta slow waves are seen. So this is spectral analysis. By spectral analysis, we'll see all the frequencies that make up the signal. And along with that, it gives the power at each frequency. And power is the 10 times logarithmic square of amplitude. So they'll provide a spectrum. You know, spectrum means all the frequencies that forms the raw EEG. So when you take this EEG waveform, this is the spectrum that it provides. So if we see, this is known as frequency domain analysis. Here on the x-axis, we have frequency, and on the y-axis, we have power. Power is square of amplitude. So if you see here, we can see that most of the waveforms are in the maximum power is in the lower frequency range. So 0 to 3 hertz in the delta frequencies. And it is followed by the next higher power is at around 10 to 13 hertz. So this is how a spectrum is formed. So from the spectrum, we'll get two other values. The solid vertical line is the spectral edge frequency 90. That is 90% of the frequencies are below this particular frequency. And the other one is median frequency. Median frequency divides the spectrum into two halves. So basically, if the SCF is low and median frequency is low, this implies that the depth of anesthesia is more. So next is what I told previously is for a particular instant or for 1 second analysis of spectral analysis. So if we want a continuous analysis of EEG, we have to analyze we have to do spectral analysis at each second, and we need a 3D spectrogram. So the x-axis will be frequency, y-axis will be power, and each frequency is at each second it is analyzed, and on the y-axis time is plotted. So a 3D spectrogram is formed, that is known as compressed spectral array. Then to plot 3D spectrogram is difficult, so we have a 2D spectrogram. Here the difference is that in the y-axis we have frequency, and in the x-axis we have time, and the power is represented by color codes. Actually, here we can see warmer the color means higher the power, and cooler the color means lower the power. So if you see this spectrogram, here we can see warmer colors, red colors are seen here in the lower frequency range. Similarly, here in the alpha range also warmer frequencies are seen, yellow and red frequencies are seen. So this is a density spectral array. Now, newer monitors provide us with a density spectral array like BIS Vista bilateral monitor. Then the Z-line monitor also provides a density spectral array. Here we can see the density spectral array provided, and this white line represents the spectral edge frequency 90. So when using the depth of anesthesia monitor, we should see both the EEG waveform as well as the number. So if you see here, we can see the waveform looks like a high amplitude, low frequency EEG waveform, and the number it's shown is 43. It's almost, it's in the depth, adequate depth. Then this waveform, if you see, we can see the almost isoelectric waveforms are seen, in between bursts are seen. So burst suppression pattern is seen. Here we can see suppression ratio of 15 is seen. So this is the value shown by Conox monitor. Here also we can see higher amplitude, lower frequency waveforms are seen. And this is the EEG module, GEEG module. Here it will not provide a number, but we can see the EEG waveforms. Along with that, the spectrum is also shown, and the spectral edge frequency is also shown. So this is with Z-line monitor. Here we can see higher amplitude, lower frequency waveform. Patient state index is around 50, adequate depth 25 to 50. And here spectral edge frequencies are shown, and the density spectral array is also being shown. So this is the waveform what you get in an entropy monitor. Then coming to EEG signatures, each drug has a particular EEG signature. So this is very important in managing anesthesia. So first I will discuss with propofol. So propofol, when used for sedation at a concentration of 2 mics per ml, predominantly we will get delta oscillations and alpha beta oscillations. So here we can see, if you see the density spectral array, warmer colors are seen in the lower frequencies. So the delta oscillations, and ranging from 12 to 25 to 30 hertz. So alpha beta oscillations are seen with propofol sedation at a concentration of 2 micrograms per ml. Now, with induction, what will happen, we can see. So this is when the patient is awake, and with a 200 milligram of propofol bolus, the higher frequencies have come down. We can see only delta oscillations. And when propofol is used for maintenance, we can see predominantly alpha oscillations and delta oscillations are seen. So when propofol is used for maintenance, the signature is alpha oscillations and delta oscillations are seen. And when you come out of propofol, when you stop propofol infusion, the characteristic signature pattern seen is zipper opening pattern. So here we can see there is this is the alpha frequencies. Here we can see once the propofol infusion is stopped, we can see there is a gradual shift towards higher frequencies. So this pattern is known as zipper opening pattern. So these are the various signatures with propofol. With sedation, we can see predominantly beta gamma oscillations. With induction, slow delta oscillations are seen. Maintenance, alpha and delta oscillations. And emergence, we see a zipper opening pattern with predominant beta gamma oscillations. Now coming to ketamine, signature of ketamine. So with ketamine, you will see higher frequencies are seen in the range of gamma frequencies and beta frequencies. So this can give false high values with depth of anesthesia monitor when we are seeing the index only, even though the patient might be well anesthetized. Now coming to dexmedetomidine, dexmedetomidine signature is dose dependent. So if you see dexmedetomidine, this pattern shows at a lower concentration at around 0.6 microgram per kilogram per hour. Here we can see delta oscillations and another waveforms are seen in 10 to 15 hertz. And this pattern looks like that of propofol alpha oscillation, but it is not propofol's alpha oscillations. These are sleep spindles. Here we can see in propofol signature, you can see those frequencies are continuous. Here it's not continuous. These sleep spindles last for 1 to 2 seconds only. So this is a signature of dexmedetomidine at slow at around 0.6 microgram per kilogram per hour. Then at higher concentrations, those sleep spindles will disappear and predominantly delta oscillations are also seen. And so we have to take care when we are using dexmedetomidine with depth of anesthesia monitor. It can provide you with a lower index values, even though the patient may be easily arousable. Now coming to inhaled anesthetics. So inhaled anesthetics, they will provide an EEG signature which is similar to that of propofol with alpha oscillations and delta oscillations. But this is dose dependent. That is at less than 1 mic, you will see alpha oscillations and delta oscillations. When you increase the concentrations at around 1 mic, there will be shift from alpha oscillations to theta oscillations are seen with higher mic concentrations. So this is the pattern when you use inhalational agents. So here we can see alpha and delta oscillations, and at 1 mic we can see shift towards theta frequencies and delta oscillations. And once inhalational agents are stopped, we can see opening up, and we can see higher frequencies are appearing here. So what are these limitations when we use with EEG monitor is that most of us, we will use combination of drugs. We'll be using a combination of drugs, propofol, phenylenediamine, propofol, dexmedetomidine, and each has its own signature, particular EEG signature pattern. So we are not sure what is a particular EEG signature with a combination of drugs. So to conclude, most of the depth of anesthesia monitor we have the EEG, raw EEG, density spectral array is also seen. So we have to analyze both, assess both EEG waveform or density spectral array and the numbers. And spectrogram provides us with rich information, and it is usually easy to interpret, and we should be able to recognize changes in EEG, and always interpret EEG with numbers and with the clinical condition of the patient. Thank you.